Okay, let's talk about some surgical dermatology. So this is going to be similar to my other things. It's all question based, and things that are highlighted were bolded in the Ollie context book, so are probably higher yield. And feel free to pause it, speed it up, whatever you want. Okay, which anesthetic has an associated risk of methemoglobinemia? So this is prilocaine. So this is why you can't use EMLA cream, which is lidocaine prilocaine, in infants because they have an increased risk because their skin isn't fully developed yet. Okay, what is the maximum dose of lidocaine for tumescent anesthesia in adults? So remember, tumescent anesthesia is more dilute and you do it to numb like an entire area. So you do it for like abdominal liposuction. That's kind of like where it started. But a lot of times they do it for like HS surgeries, big surgeries. So it's 55 milligrams per kilogram. Which anesthetic is preferred in pregnant women? So lidocaine without epi, because epi is more higher risk than lidocaine is. But it kind of depends on the situation, and you should do risk benefit analysis and things like that. But basically, the moral of the story is like if you need to do a procedure in a pregnant woman, it is okay. You can do it. Which anesthetic has the highest risk of cardiotoxicity? This is bupivacaine. What is the maximum dose of lidocaine with epi in children? So this is 3.5 to 4 milligrams per kilogram. So, which part of the anesthetic's chemical structure determines if it's an amide or an ester anesthetic? So remember, you can tell based on the name which one it is. So if it has two eyes, it's an amide, so like lidocaine, bupivacaine, versus if it has one eye, like in like procaine or tetracaine, then it's an ester. So which one it is in its chemical structure is determined by the intermediate chain, which I'll show you at the end. Okay, if you're doing a procedure on a patient that's 8 weeks pregnant, how should you position her? So in the first trimester, just the same as any other patient. But we'll talk later about, when they're farther along. Which part of the chemical structure determines the onset of action, how fast it works? So this is the amide end, and that's because it binds to the sodium channel in the nerves. So the binding affinity has to do with how fast it works. Which anesthetic has the longest duration of action? This is bupivacaine. What is the max dose of lidocaine with epi in adults? This is 7 mg per kg. I think this is the most common one that they ask you in the calculation questions, which we'll talk about a little bit later too. What concentration of epinephrine is most commonly used in dermatologic surgery? So usually it's 1 to 200,000, and this is because there's less toxicity than the 1 to 100,000. Which type of anesthetic, amide or ester, leads to a PABA metabolite? And if you know about like which one is more likely to cause an allergic reaction and cross-react with PABA, that can help you in this. So this is esters. And esters are more likely to cause allergic reactions because of this. So, what allergens cross-react with PABA? This is the pesta mnemonic. So PPD, para-aminosalicylic acid, sulfonamides, thiazides, ester anesthetics, and azo dyes. How many milligrams of lidocaine are in 1 ml of 1% lidocaine? So this is 10 milligrams. So this helps you in your calculation. So if they're saying, the person is, let's say, 50 kilograms, and we know the max dose is 7 milligrams per kilogram. So you would do 7 times 50, which is going to be 350, right? Yeah. Um, so that's how many milligrams they can have. And then if you know there's 10 milligrams per 1 ml of lidocaine, then you know that their max amount of lidocaine that they can have is 35 cc's. And this works up until a certain point. The max total dose is 500 milligrams. So if they weigh, more than that and you calculate your max dose to be higher than that, the right answer is still 50 milliliters if it's 1% lidocaine. 58 milliliters, yeah. So important to remember that and know how to do the calculation. When using lidocaine with epi, how long until full vasoconstriction? How long should you wait? So it's the textbook answer is 7 to 15 minutes. I actually just heard somebody say that they think it's actually more like 20 to 30, but the textbook answer is 7 to 15. What is the maximum volume of anesthesia that you should use for a nerve block? So like if you're talking about a digital block or something like that. 4 cc's. What is the maximum dose of lidocaine without epinephrine in adults? So this is 4.5 to 5 milligrams per kilogram. Also important to know for a possible calculation. So it's lower because the epinephrine causes it to vasoconstrict. So then it just kind of stays local and doesn't get absorbed into the bloodstream. So that's why if you use epinephrine, it's a higher number. You can use more, versus if you do without epinephrine, it's a lower number. So in a patient with liver disease, what's preferred, an amide or an ester anesthetic? So this one is an ester because it's hydrolyzed in the plasma with pseudocholinesterases, and then renally excreted, versus the amides are hydrolyzed at the liver with the CYP3A4 enzyme. What are contraindications to adding epinephrine to lidocaine? So, big one to know, pheochromocytoma. Other ones are uncontrolled hypertension. If you're doing it as a nerve block in a finger and they have severe, or a toe, and they have severe peripheral vascular disease and uncontrolled hyperthyroidism. What is the max dose of bupivacaine without epinephrine in an adult? So this is 2 to 2.5 milligrams per kilogram. What are two advantages of buffering lidocaine with sodium bicarb? So the one we think about most is that it makes it less painful because it makes the pH more like your natural blood pH so that it doesn't burn as much. And then it also increases the speed of onset, so it makes it work faster. So if you're doing a procedure on a patient that's 25 weeks pregnant now, how should you position her? So you want to do left lateral tilt at 30 degrees. What is the antidote to epinephrine? Phentolamine, and you would give it 1 milligram subcutaneously. What anesthetic would you use before you place a corneal eye shield? So this is if you're doing like some sort of procedure on the eyelids and you don't want to injure the eye at all. So you do tetracaine. You do 2 drops per eye, and it only lasts 15 minutes. What is the max dose of bupivacaine with epinephrine? So a little higher, 2.5 to 3 milligrams per kilogram. Without epinephrine was 2 to 2.5. What is a disadvantage to buffering your lidocaine and epi with sodium bicarb? So it decreases the shelf life. So it increases the epinephrine degradation. So you have to use it within a week. So a lot of people like drop their lidocaine well in advance or, mix it all together, but you'd have to use it within a week if you were adding sodium bicarb. At what ratio should you add the sodium bicarb to lidocaine? So you should do 1 milliliter of 8.4% bicarb per 10 milliliters of 1% lidocaine. What part of the anesthetic's chemical structure determines the potency? And this is also somewhat debated. Different sources say different things. But I think it's the aromatic end, because that has to do with how lipid soluble it is and then how potent it is. And then some sources say it also determines like the duration of action, but other sources might say something different. So hopefully they wouldn't ask about that. So now we're going to get into symptoms of lidocaine toxicity. So some people say it's similar to signs of alcohol intoxication. So what are the first mild symptoms of lidocaine toxicity? So the big one is um, numbness around the mouth. And then talkativeness, they might feel a little euphoric, lightheaded. They might have a metallic taste and feel restless. Okay, what about moderate? So this is when they kind of start slurring their words. They might get nausea, vomiting, confusion, blurred vision, tinnitus, tremors, things like that. And then severe is when, things are really bad and you get cardiopulmonary depression, you get seizures, it can lead to coma, even death. Okay, so here's a little chart summarizing that, and it has the doses of lidocaine that happens at too, and what you should do. So for mild, you should hold it, and then if you're resuming it, make sure you dilute it. And then moderate, you can give diazepam, and that's really to prevent seizures. Um, and then make sure that they maintain an airway, and then if it's severe, obviously do respiratory support, call 911, call a code, all of that. Um, and then it's also important to note that symptoms can occur more than an hour after administration in a fourth of the cases. So it doesn't have to be immediate, it can be severely delayed. What are risks with nerve blocks? So, you can damage the nerve because you're injecting near the nerve. Um, Also, if you remember that nerves tend to run with arteries and veins, you can accidentally put it into an artery or a vein. And then you can also damage the vessels, like in the process of doing that. So for topical anesthetics, so like lidocaine cream, Emla cream, things like that, does it work better on skin or on mucosa? So it works better on mucosal sites because the stratum corneum limits the penetration. So on mucosa, there's no stratum corneum, it works better. What anesthetic causes vasoconstriction rather than vasodilation? And as a caveat, this isn't one we typically use, but this is just like a little factoid. So it is cocaine, which used to be used as an anesthetic. And this is important to know because this is why we add epinephrine, because most of the anesthetics vasodilate, but the epinephrine helps to vasoconstrict, help with bleeding, help to keep the anesthetic truly local, things like that. Okay, if a patient uses Emla cream prior to a biopsy, which is lidocaine prilocaine cream, what will you see on histopathology? So you can see artifactual swelling and vacuolization of the upper epidermis and a basal layer split. So depending on what you are biopsying and what you are looking for, it might not be a good idea to use EMLA prior to a biopsy. Um, and that's something you can kind of discuss with your patients too. What is the mechanism of local anesthetics? So they are reversibly inhibiting sodium ion influx, so it's preventing depolarization and that blocks nerve conduction. How can you decrease pain when injecting local anesthetic? Because remember, we use a needle to do it, which is always the patient's question, like, does it hurt? So it does, but there's things you can do. So you can warm it up. You can buffer it with bicarb, like we talked about. Use a small diameter needle. So usually we do a 30 gauge needle. And then there's the gate theory of pain. So you can distract the nerves in the area by like either tapping or some people use like the vibration devices to make it less painful. If you inject slowly and start at the sub-Q and then move more superficial, that can help. And then, if you talk to them or play music, that can distract them too. And then you can also do like a topical numbing before or ice. But remember what we just said about the EMLA, it could skew your biopsy results. Okay, a patient's anxious about their procedure, so you prescribe them a benzodiazepine, but now they took too much. What can reverse the overdose? So this is flumazenil, can reverse benzodiazepine overdose. What part of an amide anesthetic is a person usually allergic to? So remember, we talked about esters and they have the PABA metabolite. So for amides, you're less likely to be truly allergic to it. Usually it's due to a preservative in the actual solution, which you can switch to preservative free to reduce that, but it's usually methylparaben or sodium metabisulfite. Okay, so when is postoperative pain the worst? So it's usually the night of the surgery, so after the anesthetic has worn off. And it shouldn't exceed 4 to 5 days. If it does, you should definitely see them back and see what's going on. What is the maximum amount of acetaminophen or Tylenol that a patient should take in 24 hours? So the standard is 4 grams, but if they're over 60, it goes down to 3 grams. And if they have liver disease, it goes down to 2 grams. And this is generally considered safer than NSAIDs or narcotics. So, like, they can still take it. It's just a lower dose in a 24-hour period. What should patients take for postoperative pain? So, acetaminophen combined with an NSAID is what works the best, and they can take them at the same time. But with NSAIDs, there is a increased risk of bleeding. So, you can warn patients about that too. And obviously, if they have like kidney issues or things like that, you should use caution when using NSAIDs. Okay, so we're gonna match the sensory fibers to what it transmits. So, C fibers, what do those transmit? So this is diffuse dull aching pain. A delta fibers. These are sharp localized pain and temperature. And then A beta fibers are vibration and light pressure. So when you are using anesthesia, this is the order that you lose things in. So first pain and temperature, then touch, then pressure, vibration, proprioception, and finally motor function. So that's why when we do procedures, sometimes we'll tell them like you might still feel pressure, but you shouldn't feel pain. And that's because, we're not giving them enough to get to the level of, you know, vibration loss. Okay, so now we're going to talk about if heart rate and blood pressure are high or low in the following situations. So vasovagal reactions. Heart rate is low and blood pressure is also low. Epinephrine reaction. Heart rate is high and blood pressure is also high. I think that one's the easiest to remember. Versus anaphylactic. So this is like they're in shock. So their heart rate is high, but their blood pressure is low. And then this is a little bit about how each of these present. So like vasovagal, they get really sweaty, they get nauseous, they might be hyperventilating. Epinephrine, they get like palpitations and they feel really anxious. And then anaphylactic, they would have hives, wheezing, angioedema, things like that. Okay, and then this is, as promised, the picture of the structure. So the aromatic end, like I said, that has to do with fat solubility. The amide end has to do with binding the sodium channel, and that has to do with onset of action. And then the intermediate chain is different for the amide and the ester anesthetics, so that determines which one it is. And that is it. Thank you.